Well, it's an absolute pleasure to be here, and when I looked at the topics, I think you're very fortunate. The planners did a great job of weaving the topics and really starting off with Dr. Jacobs, and his remarkable work was quite impressive. I realize that for some of you, this may not all be relevant in terms of what aspect of care you deliver. I believe that the talk will be on the site, so I'm going to go through the talk relatively quickly, but my goal today is just to introduce some concepts to you and maybe where we're headed in terms of managing the hemorrhaging trauma patient and this concept of trauma-induced coagulopathy. If we look at traumatic injury and the distribution, there's a trimodal distribution of mortality. This actually was done by Dr. Trunke and work that was published in Scientific American I believe in the 80s. And there are those patients who immediately die after injury, and then those patients we characterize as early deaths, generally 1 to 4 hours, and then the late deaths, those patients dying of complications from their injury. In this early phase of death, if you don't die immediately of your injury now, what is important is the contribution of hemorrhage and trauma-induced coagulopathy. This was actually work that was done by Dr. Moore, who's here with us, and they examined the cause of death in injured patients. In the gray, on the bigger one, the gray and the black are really the two largest causes of early death if you're lucky enough to survive the immediate injury. And that's CNS injury and hemorrhage. And the inset shows you, I've now colored that with red, the importance and contribution of hemorrhage. In this study, Dr. Schreiber is going to talk to you, I believe tomorrow, but this study points out if we look at potentially preventable deaths from trauma, hemorrhage is the leading cause of potentially preventable deaths, with over half of these patients dying of hemorrhage, and usually on average within 2 hours. So this really shouldn't surprise you, but while we're attempting to achieve hemorrhage control, the more blood you need, then the more likely you are to die. And this also is not only the logistics of getting you in the operating room and achieving hemorrhage control, but then this contribution of trauma-induced coagulopathy. We've made similar observations in kids. This was a study we looked at, and we see that overall pediatric mortality is very low. However, when you start hanging blood in a child, especially early blood, their mortality or risk of death is 50%. So now turning to coagulation, our normal hemostasis is a balance. We're designed if we have a cut, we want to stop the bleeding or we risk bleeding to death. But if our coagulation system goes out of control, our blood vessels would become occluded with clot, and we would not perfuse our critical tissue beds. So there's clot initiation, there's this clot formation, and in the cartoon you can see the contribution of thrombin. I just want to point out a couple of these key catchwords, and then fibrin and platelets. And then there's fibrinolysis, restoring that blood vessel while also plugging the patch, as it were, in the hole in the blood vessel, and this is called fibrinolysis. Broe in 2003 examined the incidence of coagulopathy in trauma patients, and the median time from incident to admission was 72 minutes. 1 in 4 patients were coagulopathic. If you had no coagulopathy, you had 11% risk of dying. If you were coagulopathic, your risk of dying was almost 50%. Much of the work, again, I'm very fortunate to be in a hotbed of coagulation research, but much of this work was done early on by Dr. Ernest Moore, and it was recognized that coagulopathy following trauma was highly impacted by metabolic acidosis and hypothermia. And so as a result, Dr. Moore and others coined the bloody vicious cycle. We have severe trauma, we have bleeding, and we have this resultant coagulopathy. And unless we can break this cycle, the patient will bleed to death. And on the lower part of the cartoon, you can see the importance or emphasis on acidosis, dilution, and hypothermia. So our goals, at least as we and continue today, keep the patient warm, minimize crystalloid, and reduce shock. And all our attempts are focused on breaking the cycle. So I remember when I went to medical school, this is what I had to learn about coagulation, this clotting cascade, kind of divided into an intrinsic pathway and an extrinsic pathway. And no matter how much I tried to memorize it, it didn't really matter. I couldn't remember it. But again, I'll point out to you in the lower right, thrombin and fibrin. But we've learned that this is much more complicated. And in that cartoon, we were never taught to think about the role of the endothelium, the role of the platelet, the role of tissue factor presenting cells, cell receptors or glycocalyx proteins. And I know for some of you these will be new concepts. So we've now turned to a cell-based model of coagulation, where we have coagulation, we have intrinsic anticoagulation, and we have fibrinolysis. And all these factors interplay with the neutrophil, the platelet, and the endothelial cell. In a review published from Denver, we have trauma, hypoxia, and tissue injury, and they contribute to this endothelial dysfunction. This, of course, is modified by genetics, comorbidities, medications, and again, acidosis, hypothermia, and dilution. But if we break it into three components, the end result is that we have decreased tissue, or we have decreased thrombin generation. And focus again on APC, that's activated protein C. Protein C is an endogenous anticoagulant, and now this becomes abnormally elevated. And then if we turn to fibrinolysis, we have increased fibrinolysis, this increased clot breakdown. So some new words here, tissue plasminogen activator, and then its inhibitor, PI1. But the end result is TPA and PI1, TPA goes up, PI1 goes down, and we have increased fibrinolysis. And then platelet dysfunction. So in this, we have some insult, we're bleeding, we have activation of our clotting cascade. Now the platelets come into play, and we have interaction with this thrombin generation and activated platelet, and the end result is what's called the thrombin burst, that this process as coagulation accelerates, and we now have a stable clot that's formed and presumably ameliorates the bleeding. Well, as I said earlier, this is a balance, and so we have procoagulant activity that's counteracted by anticoagulant activity. We have fibrinolytic activity that's counteracted by antifibrinolytic therapy. And trauma disrupts this balance. So again, we have an insult, we have our endogenous coagulability or coagulopathy of trauma, we have the secondary coagulopathy, and interestingly, we almost rebound into this late hypercoagulable state. In the normal state, we have our nice blood vessel, we have our interstitial space, but then in severe shock, the endothelium gets disrupted, and all that crystalloid that we're giving exudes into the interstitial space and promotes local tissue hypoxia, again, in critical organ beds. The endothelial glycocalyx has been known, but it hadn't been recognized as its importance in trauma-induced coagulopathy. This endothelial glycocalyx is anti-adhesive, anticoagulant, and protective. If we look at this electron microscopy on the left side, this is what it looks like on the normal EM. There's your endothelial cells in this fluffy glycocalyx. But look what happens when you have shock and ischemia. This glycocalyx sloughs, and that's what's measured on the bar graph at the right in syndican 1, which is one of the glycocalyces. So we basically shed this, and it actually serves as almost an auto-anticoagulation. Dr. Schreiber, I'm sure, will be talking about the importance of plasma in resuscitation, and those of you in the military that use one-to-one resuscitation, you know how important plasma is. Well, look what in the lower graph what happens once you begin to restore that, particularly with plasma. You get this regeneration of the glycocalyx and then this reduction in the endothelial leak. As I said, platelets have a whole number of receptors. We don't need to go through all of them. But this was a study here from Denver in which we showed that severely injured patients and severely acidotic patients have platelet dysfunction as characterized by the inhibition of their ADP receptor. Dr. Cohen, when he was in San Francisco, demonstrated that other platelet activating receptors were also impacted by trauma. And so, again, it should be no surprise with severe shock, coagulopathy as measured by PT and PTT are quite deranged. So again, back to a cartoon. Fred taught me many years ago to use cartoons, but we have hemorrhagic shock, we have hypoperfusion, we have this increased activated platelet, protein C, which then affects proteins factor 5 and 8, and then we have decreased pi1. So we're actually causing anticoagulation. This was shown in a rodent study by Dr. Cohen that coagulopathy increased with activated protein C. You could decrease this by inhibiting activated protein C, but if you completely inhibit activated protein C, the animals died to thrombosis. Now, what about humans? Well, again, in graph A, this is activated protein C, and severe shock is the furthest right, and we can see that in severe shock, activated protein C goes up. In B, that's your non-activated. You can see that it concomitantly goes down. And the end result in C and D is elevation in PT and PTT or coagulopathy. So now let's turn to the other side, and that is fibrinolysis. We've said that this hypoperfusion and shock results in increased plasminogen activator activity. And so as an end result, we have increased fibrinolysis and therefore more bleeding. We're learning that this pathway is heavily regulated. We have TPA, which once activated now cleaves plasminogen to plasmin, which then breaks down the fibrin clot into fibrin, which we measure as D-dimers. So there can be physiologic, as we've said, or pathologic fibrinolysis. In work done by Hunter Moore, shock increases tissue plasminogen activator. That's not a good thing. And pi1, the inhibitor of TPA, is diminished in those patients that are hyperfibrinolytic, and that's on the far left. Green is activated pi1, the inhibitor, and you can see in those hyperfibrinolytic trauma patients, they're almost absent in their inhibitor, and they're increased in their active TPA. So is it real? Of course it's real. So in Denver, it's 2% of the highest level trauma activations and 18% of those patients that are requiring massive transfusion. Similar patterns have been observed in Houston and in Europe, and in LA and San Francisco, similar to the Denver observations. So again, when we focus on this iatrogenic resuscitation injury due to the coagulopathy of trauma, it's due to this increased vascular permeability. All that saline we're giving just is leaking out of those blood vessels into the interstitial space, producing a lot of edema. You've seen it all in your patients. And tissue hypoxia. That's not a good thing. I like this study. It was a rodent model, and it was looking at, you cut the tail off of the rat, and you let the rat bleed. And so they were trying to mimic the pre-hospital phase. And then hemorrhage control is simply tie off the tail. So rats had their tail cut, They were hemorrhaging. And look what happens to the rats in the light blue that are resuscitated to a normal blood pressure for a rat. They almost uniformly die, and most die before they can achieve hemorrhage control. Heck, if you don't even give them any fluid, you do almost as well. Now, if we give them no fluid prior to hemorrhage control, then we can achieve about 50% survival, and the best survival was observed in those animals that were resuscitated, but not to a normal blood pressure. The same has been shown in swine, that the higher we raise them after an aortic injury that's been administered, that they bleed more. So this becomes important, and it's been recognized. People have written about it. Shafton and Miles both observed that giving a lot of saline to bleeding patients is not a good thing. In 1994, really a seminal work by Dr. Maddox and his group in Houston looked at aggressive fluid resuscitation in the bleeding patient. They were interested in penetrating torso trauma, and their hypothesis was if we increase blood pressure, we dislodge the hemostatic plug, we decrease clotting factors, and the net result will be increased cavitary bleeding. So patients were randomized to immediate IV resuscitation or delayed. Well, patients who had delayed resuscitation after hemorrhage control demonstrated a better survival, and there was a trend towards lower complications, particularly ARDS and acute renal failure. Well, I learned under Dr. Moore, and he was a big Shoemaker and Bishop fan. And in the 90s, we thought, well, these patients had a critical oxygen debt, and we had to ameliorate that as quickly as possible to really get them off of what we call flow-dependent oxygen consumption. And so we had to achieve these supernormal levels, and we did this with crystalloid, and in the 24 hours, the protocol group generally looked like this, and they had over 16 liters of fluid in the first 24 hours. The floodgates were open. That's my little cartoon showing the Hoover Dam off of that saline bag. So there are a lot of consequences of aggressive fluid resuscitation in the endotheliopathy of trauma. And I'm not going to go through these, but you can review them on your slides. This was validated in the Glue Grant database analysis, and this was a large registry of trauma patients. This complications occurred in a dose-dependent fashion based on the amount of fluid crystalloid they received in the first 24 hours. And the amount of fluid is in each of these graphs, and you can see that increased ARDS, increased multiple organ failure, increased abdominal compartment syndrome, and increased surgical site infection in a dose-dependent fashion. We did the same study in children and found that children too suffer from high resuscitative volumes, but we did not observe ACS, multiple organ failure, or ARDS, and it's interesting because they appear resistant to these complications. So the end result is we've seen a trend towards less crystalloid since the mid-2000s. And these are the fluid volumes that you can see on the far left that were very high during the early 2000s, and now we're seeing this trend towards less crystalloid. And that's led to the concept of damage control resuscitation and this early use of blood products and plasma. And it should not now surprise you that this strategy by resuscitating the bleeding trauma patient is associated with less crystalloid, but here we go with the coagulopathy. They end up needing less blood, less plasma, and fewer platelets. And the best is that they demonstrate increased 30-day survival. So as Einstein said, we cannot solve our problems with the same thinking we used when we created them. So this is the modern concept: blood component therapy, euvolemic resuscitation, and the use of a modern MTP. And again, you're now familiar with that slide, and when this is critical is in that first 6 hours. When we look at the percentage of blood products transfused, it's in this first 6 hours following injury. The military strategy is to replace lost blood. So if we look at how what is exactly whole blood. It's hematocrit, platelet, coags at these measurements. And this is what this component therapy mimics. In this study by Holcomb and others, looking at, now these ratios are 1 unit of blood, 1 unit of FFP, 1 unit of blood, 1 unit of FFP for every 2 to 4 units of blood, or 1 unit of FFP for 8 units of blood. And we can see that when the ratios are kept 1 to 1, mortality is the lowest, 19%. But once we get away from using these products and only giving blood, mortality can go as high as 65%. So just 2 quick studies, because I'm sure that Dr. Schreiber will be talking about this, but it was examining these ratios. In other words, low ratios where I'm giving FFP almost in the same ratio as I am RBCs. And in those patients that had high ratios, FFP to blood, they were 3 to 4 times more likely to die. They did a subsequent study seeing, was there in a civilian population any difference between 1 to 1 or 1 to 2, and there was not. They had similar outcomes between the 2 arms. We're also learning, based on a lot of work by Hunter Moore and Ernest Moore, that we have this spectrum of fibrinolysis. And why I'm going to introduce that is because we're now also being told that TXA is a panacea. And this data should cause you some alarm, because TXA, while it may be appropriate in certain patients, may be extremely harmful in other patients. So again, we talk about fibrinolysis. Well, the patients on the far right are hyperfibrinolytic. They're breaking their blood clot down too quickly. But interestingly, we have a group of patients that are in what we call shutdown, and they're clotting. And now giving them an antifibrinolytic agent will make them clot worse, and they are going to suffer thrombotic complications. Children demonstrate that they're actually more prone to shutdown than to hyperfibrinolysis. So we went through this again, and I'm now going to show you how these agents work. So we have plasminogen activator binds to it, and then there's this lysine binding site that brings it to fibrin, and it breaks down the fibrin clot. Well, these are lysine analogs, so amycroic acid binds to this, and now this activated complex can't break down the clot. That's what we want. Well, TXA has a 10-fold greater affinity for this binding site, so it's very effective in stopping fibrinolysis. But we have to go back to aprotenin, which is no longer used. This was a direct plasmin inhibitor. And when used in cardiac surgery patients, these patients suffered a high degree of thrombotic complications characterized by reocclusion of their grafts and renal failure. So the CRASH study showed us that they could decrease mortality in patients in severe shock and when given early. But when given late, it had an increased mortality. And so, as I'll finish up in my talk, we have to be better about identifying these patients that are hyperfibrinolytic or those patients who may be in shutdown. And that takes me to our goal-directed therapy for treating trauma-induced coagulopathy. PTT, INR have been our standard measures, and these tests take a long time, and remember, they're telling us about this clotting cascade, but they're not telling us about the other elements that contribute to coagulation. On the other hand, thromboelastography is an analysis in which we can examine both coagulation, fibrinolysis, the contribution of thrombin generation, fibrinogen, and platelets, and then that component of fibrinolysis. Once you get familiar with this, you very quickly learn pattern recognition. A is a normal tracing, whereas the others are abnormal, and you can look at those later. So following resuscitation of our patient, gee, if we use our standard testing, well, the hemoglobin's 7, the INR is less than 2, platelets are 50, and we might think we're doing okay. Well, if we look at the first and we get a tag, yeah, we are doing okay. But maybe we get the next tracing, And this if they're bleeding, requires platelets and cryoprecipitate. This patient, if they're bleeding, requires TXA or Amicar. And in this patient, due to the prolonged R time, probably needs FFP. Well, you say, oh, that sounds all theoretical, probably doesn't make a difference. Well, we did a randomized trial at Denver Health comparing conventional coagulation assays to TEG and what we called goal-directed hemostatic resuscitation. So all patients upon activation of MTP were randomized to TEG or to conventional assay. And at that time I was taking adult trauma call, were blinded to if they were conventional, we didn't get to see the TEG tracing and vice versa. Well, using goal-directed resuscitation versus coagulation studies, we demonstrated that you could achieve a 50% reduction in mortality. So Dr. Moore kindly has given me this slide. That there's still a lot to know, and we're getting there. But the preemptive therapy looks good. Have we achieved the optimal ratio and components? Well, we're not sure yet. And what is the role for these antifibrinolytics? And then finally, we are fairly convinced that we should use goal-directed management. So again, we've come a long way since this early cartoon of the 90s, and I'm sure in another 10 years it'll look far different. So for now, it's to address the bloody vicious cycle, it's the 5 H's. Hemorrhage control, we've heard today, the use of combat gauze, tourniquets, binders for pelvic fracture, definitive hemorrhage control, i.e. right place, right time, where there's an OR, there's a surgeon immediately available. Hypotensive resuscitation, don't pop the clot. Hemostatic resuscitation, this early use of plasma. And then homeostasis, reducing the amount of crystalloid we use. And then finally, hypothermia. So with that, we'll just turn. This is what it may have looked like in the Civil War. I'm not sure you got much resuscitation, probably a shot of whiskey. Then the surgeon cut your leg off, and then you were taken to the tent, and God knows what happened in there. And we've progressed since then. We now have this integrated concept of damage control resuscitation with damage control surgery that superimposed upon resuscitation, which is a continuum through care. It's individually tailored, it's goal-directed. And we hope that, and we've seen that it can improve outcome. So with that, thank you very much, and I'd be happy to answer any questions.